to help us conduct descriptive analysis by person, place, and time using Excel, Microsoft Excel, QGIS, and EpiInfo. Frequencies and proportions were calculated, and results were presented in tables, charts, and maps for clarity and understanding. We found out that 300 cases were reported within the period, and the median age was 3 years. And then the children below 5 years were the people who were mostly affected. And looking at the vaccination status of the AFP cases recorded during the period, more than 70% of them received 3 doses of oral polio vaccines. By way of describing the proportion of AFP cases reported by district, all the district reported at least a case within the period under review, and Takwa Inswayim and Ahanta West recorded more than 25% of the total cases of AFP recorded. And the green triangle also shows where we recorded the circulating vaccine-derived polio virus diseases. I want you to take note of this slide. This is the distribution of polio cases that were recorded within the region, and all the 3 cases that were recorded received at least 2 doses of bivalent oral polio vaccine. However, they were missed out on the type 2 protection. This slide also shows that throughout the study period, there wasn't any district that was silent on AFP case detection. And more than 80% of the AFP cases were investigated within 14 days of onset of paralysis. And consistently, the non-polio AFP rate stood above +2, which is the WHO target. We also went further to analyze data on routine vaccination. And from 2017 to 2020, it was established that the routine vaccination coverages were below the target of 90%. And when you look at where we have the bar where IPV was introduced is in 2018, and the outbreak also occurred within the year 2020. So we tried zooming into the district that recorded the positive cases to know their vaccination coverages within the area. And Takwa Inswayim, we identified high vaccination coverages. However, when we did further, the sub-district that recorded the case had below 70%. And looking at the district, Jomoro consistently recorded vaccination coverages below 90%. The study therefore established that majority of the AFP cases were below the age of 5 years. And most of us will be aware that these are the group of children who normally play in the soil, and the transmission of polio is through fecal-oral diseases, it's through fecal-oral. And these children have challenges as far as their sanitation practices is concerned. And non-polio AFP rates throughout the period was above the WHO target, which signifies that the surveillance system within the region was sensitive. And we also established that the outbreak could be due to the switch from the TOPV to BOPV, because all the cases that we recorded received at least 2 doses of bivalent oral polio vaccine without the second type and then the IPV. Therefore, we think the outbreak could be due to the switch. And we also identify low vaccination in certain areas, which is also another risk factor as far as polio immunization is concerned. In conclusion, AFP surveillance indicators per WHO targets were met, and 3/4 of AFP cases were below the ages of 5. And consistently, all the districts within the region reported at least a case of AFP, and throughout the study period, we also recorded cases. And the outbreak could also be due to the switch from TOPV to BOPV, and low vaccination coverage in some areas were also identified. With this, we didn't leave it there. We also gave some recommendations to the Regional Health Directorate for frequent conduction of mop-up exercise to cover people that were not captured, especially in areas with low vaccination coverages. And also, all districts are supposed to have geo-mapping to map up all the vaccination points, especially the hard-to-reach areas, in order not to miss any child. And we also recommend that they should intensify AFP surveillance system and clinician sensitization, as when we sensitize them, they'll be able to pick the cases as it is and to help us achieve our target. And they should also analyze the data, not only at the district level, but also to dip down to the sub-district and the facility level to be able to know the areas that we have low vaccination coverages for actions to be taken. We therefore engage the areas with low vaccination coverages with the stakeholders to tell them the need to encourage their people to accept vaccination. And also, the findings were shared with the stakeholders, inviting all the district directors and the disease control officers, letting them know what is happening within the jurisdiction. And we also engage the health workers to draw their action plans on how to conduct the mop-up within their vaccination areas. And the areas we identified to be low vaccination coverages, we also conducted mop-up vaccination exercise. Thank you very much.
Thank you, Dennis. Let's have Kokovu take the stage.
Bonjour, chers tous. Je suis Dégué Gamadé. Je suis un gradué de FETP intermédiaire au Togo. J'ai l'honneur de vous présenter le travail sur l'investigation de l'épidémie de rougeole dans le district sanitaire du Golfe au Togo. Investigation qui a été menée en février 2022. Voici le plan de présentation que nous allons adopter. En introduction, il convient de rappeler que la rougeole est une maladie aiguë, transmissible, contagieuse, mais qui est évitable par la vaccination. Elle fait partie des principales causes de morbimortalité chez les enfants de moins de 5 ans, surtout dans les pays à faible revenu et avec un système de santé précaire. L'OMS et CDC ont dénombré plus de 800 000 cas de rougeole dans le monde en 2019. En Afrique, des épidémies ont été rapportées dans plusieurs pays entre 2019 et 2020. Au Togo, en 2019, 351 cas de rougeole ont été notifiés, parmi lesquels 63 ont été confirmés, contre seulement 15 en 2016, ce qui avait placé 8 districts sur les 44 que compte le pays en épidémie. Dans le district du Golfe, en 2021, aucun des 13 cas suspects n'était confirmé. Mais subitement, le 3 février 2022, 9 cas ont été confirmés sur les 16 suspectés. Nous avons donc mené une investigation pour mesurer l'ampleur de cette flambée et mettre en place des mesures de contrôle. Nos objectifs étaient de décrire le cas index, de rechercher de cas supplémentaires, de décrire les caractéristiques socio-démographiques et cliniques des cas, de décrire l'évolution temporelle de la flambée et sa répartition géographique, et enfin, identifier les facteurs d'exposition. Mesdames et messieurs, voici les méthodes que nous avons utilisées pour notre investigation. Le district sanitaire du Golfe était notre cas d'étude. Ce district est situé au sud du Togo. Le Togo lui-même qui est situé en Afrique de l'Ouest, ici en rouge sur la carte de l'Afrique. La population des enfants de 0 à 11 mois était de 60 885 et les 1 à 5 ans représentaient 203 194. La couverture vaccinale en rougeole rubéole 1 et rougeole rubéole 2 était respectivement de 65% et 49% en 2020 et 48% et 68% et 48% en 2021. Il s'est agi d'une étude transversale descriptive qui a porté sur les cas de rougeole du district sanitaire du Golfe entre la période du 15 décembre 2021 au 21 février 2022. Les définitions opératoires de cas ont été actualisées et appliquées au district sanitaire du Golfe entre le 15 décembre 2021 et le 21 février 2022. Les techniques et outils de collecte de données que nous avons utilisés étaient des entretiens individuels avec les parents des cas confirmés et également nous avons fait une revue documentaire dans les formations sanitaires. Les données que nous avons recueillies ont été ensuite saisies dans une feuille Excel puis exportées dans le logiciel EpiInfo. Ce logiciel qui nous a servi donc de pouvoir calculer les proportions avec les intervalles de confiance à 95% et l'âge médian avec son intervalle interquartile. Voici les résultats que nous avons obtenus. Notre cas index était une fillette de 3 ans qui n'était pas vaccinée contre la rougeole. Elle a consulté le 5 janvier 2022 au CMS UTB circulaire. Devant la fièvre et les éruptions cutanées, la suspicion de rougeole a été faite et la confirmation a été faite ensuite au laboratoire. Pour ce qui concerne la recherche de cas supplémentaires, un total de 22 cas ont été retrouvés, parmi lesquels il y avait 11 qui étaient confirmés par lien épidémiologique. Il y a également 11 cas qui ont été suspectés et prélevés en consultation. Nous continuons la présentation des résultats avec l'ampleur de la flambée et les caractéristiques socio-démographiques des cas. Au total, 37 cas suspects ont été détectés, parmi lesquels 26 ont été confirmés. Le taux d'attaque cumulé était de 2 cas pour 100 000 habitants. La létalité était nulle. L'âge médian des cas était de 3 ans avec un intervalle interquartile de 2 à 4 ans. Les enfants de 1 à 5 ans ont représenté plus de 76% des cas et le ratio homme-femme était de 1,6. Sur le plan clinique, tous nos cas ont présenté la fièvre et les éruptions cutanées. De la même manière, tous les enfants de 1 à 5 ans chez qui nous avons pris le périmètre brachial avaient un périmètre brachial qui était normal. Selon l'évolution temporelle de la flambée, le cas primaire a manifesté ses signes le 12 décembre 2021, le 22 décembre 2021, pardon, et le cas index le 4 janvier 2022. L'investigation et les actions localisées ont commencé le 7 février 2022. Le pic de l'épidémie a été atteint le 10 février 2022 avec un total de 6 cas. Cette carte montre la répartition géographique des cas et ça montre que la zone de l'aire sanitaire de Amoutive avait enregistré plus de cas, suivi de Nikonakwe et de Nukafu. Mesdames et messieurs, voici les facteurs d'exposition que nous avons pu identifier. Plus de 84% de nos cas n'étaient pas vaccinés et plus de 53% avaient une notion de contact avec un cas confirmé. De plus, dans les ménages où il y avait des cas de rougeole, environ 5 personnes vivaient dans une chambre. Pendant l'investigation et durant l'épidémie, nous avons mené des actions de santé publique, à savoir l'isolement et la prise en charge des cas de rougeole. Nous avons mené des séances de sensibilisation dans la communauté pour sensibiliser les leaders de la communauté et les parents, les proches, les voisins de quartier sur la nécessité de vacciner les enfants en général et contre la rougeole en particulier. Nous avons également briefé les prestataires et les relais communautaires sur les définitions de cas pour pouvoir détecter les cas. Que révèlent les résultats que nous avons retrouvés?
Results.
il est ressorti que
we are
les
able
enfants
to
de 1 à
see
5
that
ans
children
ont
from
représenté
1
plus
to
de
5 years
65% de nos cas.
represented
Donc,
76%
il
of
convient de
our
rappeler que
cases.
ces enfants sont
So
nés
these children are
peu avant la
born
période de la pandémie de COVID-19.
before
Et aussi, il y
COVID-19
avait une faible
pandemic,
couverture
and
vaccinale
then there was a very
dans le
low
district du Golfe qui pouvait
vaccination
être liée
coverage.
avec la faible fréquentation des structures de vaccination pendant la période de COVID-19.
Or not going to the
Également,
centers during
les enfants non
the
vaccinés
pandemic.
ont représenté
The
84% de nos
ones
cas.
who were not
Ces
vaccinated
enfants
represented
provenaient essentiellement donc
84%,
des zones
and these
avec
children
une
are
forte
coming
communauté
from
étrangère qui était hostile à la vaccination.
a
Et
community that
également
was
pendant
not
cette
really
période,
open to vaccination.
à vacciner les enfants par
Then
crainte
we
du
had
vaccin
to
anti-Covid.
sensitize them that they needed to
La zone
vaccinate
de
their
Amoutive
children.
avait
In the Amotive
enregistré plus de
region,
65% des cas.
we had
Il faut rappeler que c'est
65%
une zone qui est hostile généralement à la
is
vaccination
a region
et
that
également une zone
really
où règne
welcome
une forte
vaccination.
promiscuité.
That is how this
En conclusion,
explains. And
nous
in
devons retenir
conclusion,
que
we've
l'épidémie
got
de
to say
rougeole
that this
que
mission
notre district a
problem
connu était caractérisée
was
par
characterized
les enfants de moins de 5 ans,
of less
vivant
than 5
majoritairement
years
à
who
Amoutive.
live in Amotive.
Cette épidémie a été favorisée
This
par une faible
pandemic
couverture vaccinale et une forte promiscuité.
was due to
Nous avons
less,
recommandé une vaccination systématique pour tous les cas
so we sensitize people that they
et
need
une
to
étude cas témoin pour identifier les facteurs de risque.
vaccination coverage and avoid
Des
the
recommandations ont été adressées au district
social
sanitaire du
risks.
Golfe. C'était de poursuivre la réponse vaccinale localisée, d'organiser la recherche et la vaccination des enfants non vaccinés. Et pour le niveau central, d'organiser une campagne de vaccination contre la rougeole avec pour cible les enfants de moins de 5 ans. Voici quelques références que nous avons exploitées pour élaborer notre travail. Nous ne saurons terminer cette présentation sans remercier les partenaires et notre équipe d'encadrement. Je vous remercie.
Thank you. Merci, Kokouve. Let's invite Suma Nabe Mariama.
Bonjour, moi c'est le Dr Souma Nabi Mariama, je viens de la Guinée-Conakry. J'ai l'honneur de vous faire la présentation sur l'évaluation du système de surveillance épidémiologique de la rougeole à Breakout en août 2021.
Of dealing with the this is how I'm going to present. In Guinea, this surveillance system is an integral part when we talk about other diseases. Since 2015, this is done case by case with an objective to determine and collect and notify, at the same time, confirm cases so that there is care taken, so that we can put in place an adapted health care system. For this case, you are able to see how information was dealt with from the grassroots to the topmost area. The objective of this study is to evaluate the surveillance system of measles and come up with a better way to see is it acceptable, the data. Do we have the right data? Is it representative, and how representative this system is? Guinea wants to eliminate measles, and the first outbreak, when we depend on the surveillance system, we didn't really have much, and this system is supposed to be revised periodically. And this is going to help us to do eradication of the disease. These are the kits that were used, CDC 2001, to see how functional the system is. The surveillance standards through vaccination in 2018, so that we can use the indicators that are necessary. The functionality was revised because we compared what is described and what is observed. We had interviews with those ones who are responsible. And the simplicity of this system, this was done through interviews. The quality, the acceptability of the data, the sensitivity, all these were assessed using basic information from 2018-2021. When it comes to functioning and who has what as a responsibility, we worked in different levels. We had notification at the community level and in health centers. There were delays on sending the reference, sending samples to the laboratories, and decision making was delayed, and there was no feedback from the top level towards the grassroots. The simplicity, this was assessed given the following indicators. Those ones who can simply define the cases. Is the investigation form simple? The circuit of notification of the information, is it simple? This is how we worked. As a result, when it comes to simplicity, no indicator was respected or responded to. Acceptability. This was evaluated given the proportion of cases of measles with samples taken, the investigation rate, suspected cases of measles, and the number of samples taken to the laboratory in good condition. When talk about acceptability, 3.6% when the investigation was done, this benefited from samples of blood. Completeness, what has been investigated during 2 days, and the samples that have been taken to the laboratory before 2 days. And the return of information before 7 days, and how these cases were dealt with after notification. When it comes to promptness, no indicator was respected or achieved. When it comes to the quality of data, we did completeness of the data using the forms, and we used the investigation form in DHS2. As a result, only 77% of the data was complete. 99.7% of the correctness of the data in DHS2. The positive value and sensitivity value, the proportion of people identified by the surveillance system as being really confirmed cases of measles, and other cases which were rejected. This is at 87% sensitivity for 2 million. Representativeness, we had to see the spatial distribution from 2017-2021. Usefulness, we had to see how useful the system is, how many outbreaks were detected and dealt with, and how many samples were taken to the laboratory for testing and confirmed. This system was representative at the health centers, only that 2019 there was not really much work which was done. During this period, 2017-2020, we had to take samples to the laboratory for confirmation. Given all that I've presented, we can say that our system is functional. When we talk about a few weaknesses here and there, sensitivity, there is a good representation during the time of the study. Given this problem, we had to carry out some actions involving all the stakeholders and giving a feedback to the actors, and this had an impact when it comes to improvement of the data in DHS2. At the same time, how partners were going to position themselves when it comes to sending samples to laboratories. After this work, we recommend that these samples being taken to the laboratories at the right time, and then we organize how we fight back once cases are confirmed, and then the health centers, health workers are supposed to be sensitized on how to detect measles cases. Reference was done to do this work, and we thank the Ministry of Health and through ICDC AFENET. And that being said, I thank you very much indeed.
Thank you so much, Nabe, for that presentation. Please take note of all your questions. At the end of the presentations, we'll have a question and answer session. Our next presenter is Fode. Please take the stage.
Bonjour, donc moi c'est Dr Fode Damfaka. Je suis spécialiste en santé publique.
I'm Fode, expert in public health.
Donc je m'en vais partager avec vous.
I'm going to share with you the investigation that we had on paralysis that we had in the district of Kedu in June 2021. So to start our work, we are going to use this outlook for introduction. We should say that Senegal had its polio case, wide polio in 2010, and in the district of Kedu had been notified 3 paralysis case. That is a case by year. But district has noted 3 cases within a week, and the case was within the same district. So that's why the district decided to undertake a preliminary investigation. So it was noted that they had a sheep who had the same symptom, and we also had other cases within the same community. That's why it was necessary to send the information at the central level so that they can deploy a team for investigation. So we had 2 objectives. That is how to have epidemiologic investigation within these cases, and particularly to describe clinic biological characteristics and find out the real causes. And it was necessary to also evaluate the impact of polio within the Kedo district. As methods, our framework, the framework for our study within the district of Kedu, southeast of Senegal. This is a district where we have about 42 centers with 171,000 and a density of 11 persons per kilometer. So there are normally they are mining, in fact, gold using mercury. So what they're using as method is that we came up with a study which was done from 21 May to 13 June. So here we are talking about very severe paralysis cases which was found within women and animals. So we have first of all to define what is the case. That is anybody living in the district who was limping or had paralysis was taken into account. So we came up with 4 tools to do the to collect the data. So we did it individually. So we also have to take blood and hair from human and blood from the animals to do the study. So the data that we came up was based on the demographic characteristics and samples from animal and human. So we analyze data using the KG info. So as far as results are concerned, so here we have a special result. We had in total 29 cases within human being, and you can see that 28 of those cases were within the Kedu district, and 1 was in the neighboring district. So here you can see people from 15 to 60 are among the people who are more affected. And
mais là aussi, on s'était rendu compte que le sexe féminin était prédominant, aussi bien chez les humains avec 62% que chez les animaux avec 87%.
Male, that is for a prevalence rate of 68%. Here you have the repartition talking about the chronology of the appearance of symptoms. For the most cases, the symptoms started on March 5th, and from 14 to 11 June, we can see that most people had the symptom during that timeline, that period rather. So we did have sample of blood, urine, and hair, and we found that the concentration was very high, sometimes 1,000 more than what is allowed by WHO.
5,11.
You find 11, even a high level within the blood or hair test, which means that there is intoxication within human being. So any other things we did was to test the mercury level within the water. So we came up with borehole and other water sources so that we can isolate mercury at a high level, so it could have been very high. So we did the sampling from 2 boreholes in Pondala and Bantoko, and we did also the other water sources. So we noted that the level were pretty high in the other places where we worked. So in terms of discussion, so we noted that women were more prone to develop symptoms, and it has been confirmed through some studies which has been done back in 1919, and Manga and all 1976 showed that women were 3 times more susceptible to be affected. So we came up with the water result, and then the level of mercury was very high, and we noted that this is what has been noted in other studies. So we also noted that every year the rate was doubling. This is from the study of Ndiaye Ibrahim in 2016, but study by Bantakok. So this, we conclude that the intoxication was pretty high. So we also had samples of fish, because you know that usually the fish we came from those rivers had a high level of mercury, which means that there's a negative impact of mercury in these rivers. To conclude, we should say that result has demonstrated that there is a high level of mercury within the environment as within human beings. So that's why we need to come up multi-sectoral solution. And it has been recommended that we need to evaluate the impact on the use of heavy metal within these mining sites. So I think that 80% of the recommendation that has been made has been implemented by the health, public health. So we wanted to sensitize the authority on the ecological risk. So we did share our result during the CDD with governors, and other sectors were represented, as we share with the Ministry of Health our result, and the sharing should have been done also within the community, so that they can understand the risk of using mercury to mix gold. So this action had helped us to secure funding so that we can train, qualify staff and community staff on the treatment of intoxication cases. We came up with a software for surveillance, so that a community, whenever they will not symptoms, they can notify, and it was done with the support of OUM. So we are going to conclude by thanking the Ministry of Health, AFENET, and FATP Senegal, as well as other partners, and those are the references that we use for our work. Thank you very much.
Thank you so much, Fode. Our next presenter is Manuela Alphonse from South Sudan.
Okay, thank you. I'm Manuela Alphonse from South Sudan, a graduate, frontline graduate from FETP. I'm going to present to you the effects of coronavirus 2019 pandemic on turnaround time for the laboratory testing of measles samples in South Sudan 2021 and 2020. Sorry. The laboratory turnaround time is the time taken by the laboratory to release results following the receipt of samples. Turnaround time is a quality indicator of the laboratory performance. COVID-19 pandemic interrupted the laboratory surveillance of the most disease, including measles sample, which is targeted for elimination. In South Sudan, laboratory performance of measles sample testing during COVID-19 was not well understood. Therefore, we evaluated the performance of measles sample testing before and during COVID-19 pandemic. We analyzed data for 1,515 measles samples tested at the National Public Health Laboratory during 2018 to 2021. We calculated the median and the interquartile range of the turnaround time intervals, compared calculated turnaround times with the recommended IDSR turnaround timelines. This diagram shows us the recommended IDSR turnaround timelines. As we can see, The surveillance turnaround time is the time in days from sample collection to sample receipt at the National Public Health Lab, and the target is 3 days. The laboratory turnaround time is the time in days when the samples are received in the National Public Health Lab and the results sent to the surveillance, which is 7 days target. Overall turnaround time target is when the sample is the time from sample collection to the results sent to the surveillance, which is 10 days target. This table shows the median and the interquartile range of measles surveillance, laboratory, and overall turnaround time before and COVID-19. As we can see, the surveillance turnaround time and the laboratory and also the overall during COVID-19 was higher compared to before COVID-19. This one. The proportion of measles sample with the turnaround time within the IDSR target before and during COVID-19. As shown in this graph, that the surveillance proportions of measles samples for surveillance, laboratory, and overall are lower within the IDSR target before COVID-19 compared to during COVID-19 compared to before COVID-19. Proportion of measles sample within turnaround time within the IDSR target before and during COVID-19 by state. South Sudan has 10 states. The proportion of measles surveillance turnaround time before COVID-19 were very low were very low compared to before COVID-19 across all the states, except Western Equatoria. However, three of the states, non-samples received during COVID-19 within the IDSR target. This is also similar to the laboratory turnaround time during COVID-19. The surveillance laboratory overall turnaround time during COVID-19 was longer and not within the recommended IDSR timeline. This may be attributed to more focus on COVID-19 testing and response. Upper Nile, Unity, and Warapi State had low proportion of sample within the IDSR recommended turnaround time during COVID-19. This is due to the hard-to-reach states and the sample transportation to the National Public Health Lab is by flight. Action taken. These findings were presented to the weekly EOC meeting, and also the findings were shared with the state, county directors, and surveillance laboratory pillar leads. We recommended detailed investigation of the delays and subnational testing hubs to minimize delays. Thank you.
Let's welcome Alpha Raoul from Benin.
Good morning, everyone. My name is Raoul Asobape. I come from Benin. So I have the pleasure this morning to present to you the study on the epidemiologic profile for the flaccid and acute paralysis in Zoo, the district of Zoo in Benin from 2017 to 2021. So what is the outline of my presentation? We start with introduction, methods, results, and then discussions. We should say that flaccid and acute paralysis of the members, it's actually through the research of this flaccid and acute paralysis that we can detect the cases of polio. And polio is actually a contagious disease, and it's caused by the polio virus. It's actually a public health issue that is an international one, and transmission is exclusively between human beings, and it's through the oral way. Prevention, it can be done through vaccination. So in the world, there's a reduction of about 99% of polio cases since 1988. Type 2 and type 3 of poliovirus are certified and have been eradicated since 2019. In Africa, type 2 has been eradicated through vaccination. And I can tell you that type 2 has appeared since 2018. In 23 African countries, more than half of 1,700 cases that have been registered in the world. So there's an introduction to a new oral vaccine against polio, type 2, and it was introduced in 2020. From 2019 to 2021, Benin registered 20 cases, confirmed cases of polio type 2, and we had isolation of enterovirus in the water that were polluted. And from 2020 to 2021, there were 2 cases of poliovirus type 2 that were confirmed. That's why it is important to undertake this study. So this is the case of our study. It's the district that is in the southern part of Benin with 9 zones. And we are bordered by 6 other districts. So the methods of this study, it's actually a cross-cutting descriptive study that is studying 108 cases, and the population is actually children from 15, who are less than 15 years old, from 2017 to 2021. The source of data is actually a database of SIMR, and we extracted this data from this district of Zoo to present to you the results that we are going to see shortly. So we're going to analyze all this data through the software that is called EBI Info version 7.2, and we also have the Excel table, and the mapping will be done through QGIS. Now, we're going to present to you the results. We've noted that boys that are actually strongly represented with a proportion of about 60% with the ratio of 1.25. And the children that are 1 to 4 years old that are strongly represented and a proportion of 15%, and the median age is about 3 years old. Most of the cases are in the rural areas with a proportion of 86%. So when we talk about the vaccination status, for these cases, we've noted that more than 60% of these cases have received more than 4 vaccines. And we also have the status of zero dosage. So, what is the level of notification of these cases in this particular district from 2017 to 2021? The expected level was about 13 to 14 cases. But the notifications could detect more than 20 cases each year until we reach 23 cases. In 2020 and in 2021, 2 cases have been confirmed. So, what is the tendency of notification of these particular cases? We've noted that from April to October, that is actually during the rainy season, we have more cases. There's a recurrence of these cases. So, we said earlier on that we had 2 confirmed cases, and what are the zones where these cases were confirmed in 2020 and 2021? We have the zone of Zakota and the zone of Reke, and you can see that they are really close to each other. So what are the performance indicators that we observed from 2017 to 2021 as far as PFA, non-polio? We have superior or equal to 3 cases per 100,000 children, and for that period we are above that threshold. PFA that was notified 7 days following the paralysis, and it was superior or equal to 80%, and we noted that this threshold might even go up to 100%. So, the indicator for PFA with type 2 during the paralysis for 48 hours, we are beyond 80%. So now, as far as the discussions are concerned, we said that the children from 1 to 4 years are majority with a proportion of 95%, and the ratio is 1.25 for the boys. Abubakar Conte et al. Undertook the same study, and they said that children from 1 to 4 years old have 74% as proportion, and the ratio you can see it there. So, 83 cases out of 100 accumulated cases were notified in the month of April to October. And the seasonal tendency of these cases, I told you that it was during the rainy season, and the antivirus was isolated. So in Accra and Cote d'Ivoire were doing the same study, and they found more cases during the rainy season, and the antivirus was isolated in the environment. So 60.19% of the cases received more than 4 dosage of polio vaccine, and 2 cases of polio type 2 were confirmed. And they received more than 4 dosages. And 2 cases that were confirmed received more than 4 dosages. Abubakar Conte in Guinea in 2018 undertook the same study and found that 70.07% of the cases received at least 3 dosage. So what are the recommendations? We need to strengthen the surveillance of this PFA, and especially during the rainy season. We also need to sensitize the involvement of the communities and do some studies as far as the associated factors are concerned. What are the public health actions that were undertaken? Investigation, rapid investigation, and geomapping around the new cases. We also did some monitoring of this residual paralysis, and also a response, a local response with the vaccine. And we did it in at the national level, and also to have some campaign from 2020 to 2022. We also intensified the research. In in conclusion, the cases of PFA from the age 1 to 4 years are majority, and it's most of the time in the rural areas, and there are 3 indicators of performance of the surveillance that have been reached, and we have 2 households of this outbreak from the polio type 2 that were registered in the district of Zoo, and we also had some campaign to fight against this polio with various mass campaigns. So we cannot finish this presentation without thanking AFENET, CDC Atlanta, and the coordination of AFENET Benin. Thank you very much for your kind attention.
Merci, Raoul.
Thank you very much, Raoul.
Another round of applause for our presenters. It's now time for the audience to engage our 6 distinguished presenters. We've heard a lot about the work that they've done in the field. It's now question and answer. And I'll be glad if each one of them can get a question in the next. We have less than 10 minutes to the next session. So let's take the microphone, Dr. Yaya. Yours is on?
I hope.
No. It's okay.
So let's start with you.
Okay, thank you.
Make it straight and specify who is your target.
Okay. Merci. Moi, je suis Dr. Yaya.
Thank you. I'm Dr. Yara. I am an epidemiologist and I'm a doctor. I work with AFENET, and I've been working on polio and other preventive diseases that can be prevented by vaccination. I thank the presenters for the quality of their presentations, which raised so many questions. My first question will be addressed to Dennis, who made a presentation on polio. According to the analysis of his data, I see that Ghana has got an epidemic of polio, but according to the interpretation that he gave, as regards the rates of non-polio, saying that superior is equal to 2, it means that Ghana is endemic to polio. I would like to have more precision on that. Is Ghana endemic to polio? My second question is addressed to Kukuni from Togo. I would like to know why he measured the parochial perimeters for the case of measles. I would like also to know, was the second dose of measles introduced in Togo? Because I saw a passage where there was a significant proportion of vaccinated people who developed the disease. I want to know whether those people who developed the disease had received 1 or 2 doses. Now, what are the actions of public health workers towards those people who are vaccinated or not vaccinated, who developed that disease? The other question is, since measles is very contagious, it's one of the most contagious diseases that we can vaccinate against.
Quatrième question à Fodé, Sénégal.
To Fodé from
J'ai vu que 3 métaux lourds étaient en question, mercure, plomb et cadmium. Mais dans la conclusion,
lead, mercury, and cadmium. But
finalement, le mercure a été trouvé comme cause de cette paralysie flash. Je voudrais savoir quant aux autres, comment vous avez éliminé.
Acute flash paralysis. How did you go about it? Thank you.
Good morning, everyone. Thank you very much, presenters. My name is Suzanne Kiwanuka, Makerere School of Public Health. My question goes to the lady from South Sudan about that test turnaround time for measles. And I'm curious whether within your analysis you were able to see how responsive the system, the laboratory system was to the COVID pandemic, to see whether these test turnaround times were reducing over time since you assessed them from 2020, 2021. My thinking is surely the system could have adjusted and the test turnaround time reduced as an indicator of the system's resilience. Just wanted to know your thoughts on that. Thank you.
Okay, so my name is Simon, and my question goes to Dennis. Dennis, I saw that you did a wonderful presentation, and I saw some recommendation and some public health actions where you did some vaccination. But I'm curious to find out what are your recommendations for the cohort that makes the type 2 vaccine? I want to find out what you did. Thank you.
Merci.
Thank you. My name is Kanu Yamdi. I come from Togo. My question is addressed to the third presenter who evaluated the surveillance system. We saw that as regards the opportunity of intervention, he talked about 40%. I would like to know on which basis he fixed that objective there. It's a document that he presented. Thank you. Yes, good morning. I'm Dr. Joboy Yandisu. I'm a veterinary doctor. My question is addressed to Mr. Fode. Dr. Fode, if I remember well, from Senegal. Since he presented to us here a very magnificent investigation, I congratulate him. I would like to know, since the investigation was undertaken in my sectoral framework, what are the actions which have been undertaken, which were undertaken for animals? Here, for example, I can, if my memory is good, could you please explain to us how you took in account the animals?
I'm Dr. Nkrumah from Somaliland. I asked him, two questions. Number one, some of the language, the French, but I can hear in the translation. How the coverage of the polio of that area to the South Sudan and other like that, If there is these people of taking, the polio, unvaccinated or covered area. Second question, for example, how should the cross-border area, because, this polio, they go in all of the area. For example, as if I mention our side, there's the cross-border collaboration, the area, Kenya, Ethiopia, like that. If we see one case, we can take in the action, and there is, some committees and some committee of the cross-border like that. If they have like that.
Good morning. My name is Stephen Longa Chanda from the Zambia Field Epidemiology Training Program. My question goes out to Manuela from South Sudan. You showed us that you had one area or district that showed reduced turnaround time, which was Western Equatoria. I just wanted to find out what could have led to that. Were there any specific things that you found that showed this reduction in turnaround time during the COVID-19 pandemic? Thank you.
Thank you so much, audience. I think we have 7 questions. Let's allow the presenters to respond. Thank you so much. Each one of you has at least 30 seconds to try and respond to questions that are relevant to your presentation. Thank you.
Thank you very much for the questions. Dr. Yaya, you wanted to find out whether Ghana is endemic for polio. Ghana was on the verge of being classified to be polio-free until 2019, where we started recording circulating vaccine-derived polio virus. And as I presented, Western region recorded 3, and all of them came in the year 2020. So as we speak, Ghana is not endemic for polio. And the second question was from Simon from Ghana. I think you wanted to know the recommendations and actions that was taken for the cohort that missed the type 2 protection. Thank you very much. For that cohort, they didn't receive the IPV vaccination because they had already passed the threshold that needs to be vaccinated. So what we did was to sensitize the various level at the community level for them to improve on their sanitation as the disease transmits through poor sanitation. And other actions that we've done is also we have collaborated with the national, because in Ghana we have environmental surveillance that we have prioritized sites. So we've collaborated with national to institute environmental sites within the region to test whether we have the virus circulating within the environment. Thank you very much.
Merci.
Thank you to all the speakers for the questions they have asked. That shows the interest you have in our presentations. Dr. I wanted to know why we measured the brachial perimeter. That perimeter there is an indicator of the nutritional status of the children. That is translated in some way to the immunity of those very children. That's why we took the brachial perimeter for those kids who had measles. The second dose, the second anti-measles dose was brought in Togo 5 years ago already. For the cases that were not vaccinated, those were cases which had received no anti-measles vaccination at all. The public health activities we undertook for severe cases were hospitalized, and there was also supplementation of vitamin A, and we undertook sensitization campaigns in the communities to sensitize parents and community leaders on the necessity of vaccinating children against measles. Thank you. Thank you. I thank Dr. Yeya for the question that he addressed to me, given that measles is a very contagious disease. You talked about how we wanted to know how we calculated the sensitivity to those based on the World Health Organization document that we used in our method, which talks about the rate of settlement detected in all the districts, all the people who were detected, and how many were rejected. So we calculated the sensitivity based on that phenomenon. I thank you. The second question was related to the objectives regarding sensitivity. 80% of promptitude, given that we had new cases and that at the same time we consulted documents from CDC on the number of diseases that are preventable by vaccination. The objective as regards sensitivity should be equal or more than 80%.
Merci.
Thank you. I thank all those people who have asked questions.
Pour la première question,
for the first question,
vu qu'il y a 3
given that there are
été
3
isolés, c'est vrai.
districts which are isolated, because when you take water, we had identified mercury,
le plomb. Mais sur les prélèvements humains, on a vu que c'était plus des taux de mercure qui avoisinaient les 571 fois la normale. Mais l'autre chose, c'était que les signes d'ataxie, de paralysie étaient plus corrélés à une intoxication au mercure.
This information was also correlated with intoxication that made us to retain mercury as the cause of those
paralysie flasque aiguë.
those cases of acute flaccid paralysis.
Je suis content d'avoir
I'm happy to have
entendu cette question parce que c'est une
heard that
diapositive
question
que j'avais
because
élaguée.
that's
Effectivement,
diapositive that
pour
I
les
left
animaux,
out.
vu
For
que
animals,
c'était
given
une
that
investigation
it was an
multisectorielle, donc il y avait la santé animale,
there was also
l'environnement et la
animal
santé
health,
humaine.
environment,
Maintenant, des
and
prélèvements ont
human
été
health.
faits chez les
Now,
16 moutons. Il y a au total 16 moutons qui présentaient des
samples
signes.
were taken from
Les
sheep,
prélèvements de sang
16
ont été
sheep.
faits. La recherche de
Blood
causes
samples were taken
infectieuses
from
a été
sheep,
faite avec
we analyzed infectious
les arboviroses qui ont été
possibilities
recherchés,
with
mais qui étaient revenus
arbovirus,
négatifs.
which were looked for,
Mais
but the
la
results
seule
came out
limite, c'était
negative.
qu'on ne
The only
pouvait
limit
pas
was that we
tester
could not
le
test
dosage du mercure, des métaux lourds chez
mercury
les animaux,
dose
parce que le
in
laboratoire
heavy
qui est au niveau du
metals,
Sénégal ne pouvait
because
pas tester
laboratories
chez
in
les
Senegal
animaux. Donc
could
ça,
not
c'était une
really
limite quand même
do that for
concernant
animals. So
cette
that is a
étude.
challenge we had
Et
regarding
c'est
this
pourquoi
study.
nous avons dû, sur
That's
les
why
recommandations,
we said
d'évaluer
in the
l'impact.
recommendation that we
Parce que
should
cette
assess the
évaluation
impact, because
permettrait
that assessment
doser
would
aussi
enable
bien
us
chez les
to
animaux,
dose on the side
au
of the
niveau de
animals,
l'environnement
but
que chez
also
les
on
humains,
the
mais
environment
sur
and
l'étendue quand même
humans.
du
But
district.
in the
Donc,
districts
je
we are
pense qu'on
working
est
in,
à l'attente
I
de
believe
financement
that
parce que
we
les
now
tests
are
coûtent
waiting
extrêmement cher.
funding because
ça,
all this
ce n'est
costs
disponible
out
qu'au
of
niveau
money.
du
It's
privé.
only
Merci
available
beaucoup.
at national level. Thank you very much.
Suzanne, thank you for the questions. You ask, did the turnaround time for the surveillance and the laboratory had reduced? The answer is yes, it had reduced after COVID-19 from the period of 2022 to 2023, yes, it had reduced, though we have not done studies on that, but from the from the observation and from the laboratory data and surveillance data, we have observed that. To Stephen, you have asked why Western Equatoria. The proportions of measles sample in that state especially was a bit higher because that state has regular flights. And also there's a mean of using vehicles to transfer or to ship samples to the National Public Health Lab on daily basis. I hope I've answered you correctly. Thank you.
Merci, moi, je n'ai pas.
Thanks very much. I don't really have questions, but I thank the public to have listened to us. Thank you very much.
For our presenters, we've already taken 10 minutes off the next session. Let's allow them walk off the stage. And I would like to hand over to the next session moderator, who is in the room, Dr. Samuel Asegid, Program Director, Ethiopia. Over to you.
Good morning. Just an announcement. A bag and a T-shirt were picked separately at the swimming pool, so you can check at the security from the reception. If that's yours, then you pick it. Thank you.
A very good morning, everyone. Good morning. So we'll be starting the next session. Our session subtheme will be vector-borne disease and neglected tropical diseases. I will call the presenters. This will be a poster presentation. Wamaka, are you around? Wamaka? Solange? Solange? If the presenters are around, please come to the podium. Agnes? Agnes? Agnes from South Sudan. Wisdom? Wisdom from Ghana. Joseph? Joseph from South Sudan. So you are? So is Solange around? Okay. So we'll start our session. Each presenter will have 5 minutes to make their presentation. So without further ado, I will invite the first presenter, Wamaka, to make his presentation. So I have Maria and Banda will serve as the evaluator. So we'll continue our session. So Wamaka, the floor is yours. 5 minutes, okay?
Good morning. I'm Akuzike Banda. I'll be presenting a study on the role of eating out and physical contact with a patient in cholera transmission in Salima District, Malawi, October 2022. So I'm presenting on behalf of my co-author, Wamaka Msobori. So as of September 4th of 2021-2022 cholera season, 18 districts in Malawi had out of the 29 districts in Malawi had reported cholera cases. So cumulatively, we had around 1,862 cases, as well as 72 deaths recorded. By 18th of 2022, Salima district only had recorded 149 cases within 7 days. This prompted us to conduct an outbreak investigation to determine the magnitude and the risk factors. We did conduct an unmatched 1-to-1 ratio case control study, and then we used the line lists to determine the cases. For the controls, we identified this from the relatives as well as the neighbors. We did an interview for health workers, 6 health workers. We also conducted an environmental assessment to see the condition of the environment. However, we did not collect stool and water samples because the district by that time had already collected these water samples. We conducted a logistic regression to determine the odds ratios. From this study, out of the 43 cases that we had interviewed, we found that 34 were males and 9 were females. The median age was 25, and the majority of cases, that is 17, were within 20 to 30 years of age. Most of these were fishermen. Of the 11 samples that we had collected, the district had collected, 10 of them came out positive of Vibrio cholerae. When we did the risk factor analysis, we found that history of eating out, occupation as fishermen, and physical contact with a cholera case had significant association with transmission of cholera case. In conclusion, the study found that the disease was spreading rapidly among the fishing communities and that poor hygiene was contributing to the spread of the disease. As you can see from the picture, this was open defecation in an unused canoe that was taken from the environmental assessment. And we recommended that the district emphasize on health education, on hygiene and sanitation at household and community levels, as well as regular inspection for food premises. And finally, also recommended that we training health workers on cholera case management. Thank you for your attention.
Thank you, Amaka, for using your time effectively. So as Solanga is not around, I will invite the next presenter, Agnes.
Good morning, everyone. I'm called Agnes Jokudu, graduate of FETP Frontline South Sudan, presenting cholera outbreak among IDPs in Bentiu Community State, South Sudan. Globally, cholera accounted for 2.9 million cases and 95,000 deaths. It is a public health concern in countries like South Sudan, experience humanitarian crisis and unprecedented flooding. On April 14, the Ministry of Health National Lab confirmed cholera, Vibrio cholerae stool in sample of IDP camp. So from there, we conducted investigations to characterize the outbreak. We determined the magnitude of the outbreak, identify the source, and implement control and prevention measures. The method we used, suspected cholera case was any resident of Bentiu IDP camp with onset of 3 or more loose stool within 24 hours or dying from acute watery diarrhea from March to October 2022. A confirmed case was a suspected case with Vibrio cholera infections confirmed by culture. We conducted active case search in IDP, review medical records, and listed cases. We also tested a stool sample using RDT and transport the positive result for confirmation at national lab. We tested household drinking water for coliform bacteria and inspected toilet facilities. We also calculated the frequencies, proportion, case fatality rate, and plotted epi curve. In a result, we identified 424 cases, including one death with a CFR of 0.2%. The median age was 17 years. The age group 0 to 4 years and female had more cases, as shown in the graph. This is a continuous common source of epi curve, which saw number of cases dead by epi week of onset 2022. The first case was recorded in week 11, followed by one death in week 12, and the highest peak was in week 19, followed by the declines of the cases. Out of the 51 RDT positive sample tested, 29% were confirmed with Vibrio cholera by culture. 39% of household drinking water sample tested for positive for total coliform. Only 2,642 functional latrine serve 108,456 persons in the IDP camp, which is below the standard rate of WHO, which says one functional latrines per 20 persons. This is the picture showing the hygiene situation in Bentiu. Conclusion, cholera affected mostly children, may attribute it to drinking contaminated household water and inadequate proper toilet facilities. The action taken was implemented a wash program, provide support treatment for the cases, and also admit 2 rounds of OCV. Thank you.
Thank you, Agnes. The next presenter will be Wisdom. Wisdom, the floor is yours.
If you say Ghana, it's not there. If you say Ghana presentation, it's not there. fournir ici. Que les nuits. Add a sign into it, ici. Yeah, submit.
Maybe.
Check.
Unless, yeah, so unless you find, let's take questions and we will, continue session after. We'll include in the next session. Yeah.
It's still the same session, but the second round.
Yeah, second round. No,
Just the same session. So, but let's rectify it.
Yeah.
No, let's rectify.
Hello. So we missed Wisdom's, just Wisdom's presentation. So Joseph will be, his one. This one. What you missed this one?
Wisdom, yeah, that is. And then there's wisdom there. Yeah. So Joseph, Hikin, Lazu.
So Joseph, no?
Okay. So let's try Joseph. That one is there.
Yeah, Joseph. Yeah, okay. So we missed Wisdom's presentation, but we will find it out. So the next presenter will be Joseph.
It's a touch screen. Yeah, good morning, colleagues. I'm Joseph Lasu from South Sudan, and I will be taking you through my presentation, which will focus basically on cholera outbreak investigation in Malakal County. County is an equivalent of districts in some countries. And Malakal County is located in one of the states called Upper Nile State, equivalent to regions or provinces in other countries. I will not delve much on the definition. This is all known to us. And I remember one of my professors said cholera is eating and drinking feces. So it's a bacterial infection that is caused by Vibrio cholerae. The burden, as alluded by one of my colleagues from South Sudan, these are WHO estimates that annually 1.3 to 4 million cases of cholera occur, and about 21,000 to 143,000 deaths occur annually. South Sudan is one of the high-risk countries, and that is well mapped out by the Global Task Force on Cholera Control globally. And indeed, we also did risk assessments and hotspot mapping of all our areas in South Sudan. On February 22nd, the Ministry of Health received an alert from Malakal County in Upper Nile State regarding 2 case patients who had presented with acute watery diarrhea and testing positive on rapid diagnostic testing. And following that, we did a partial activation of our Public Health Emergency Operations Center and instituted an in-depth epidemiological investigation into the suspected outbreak in order to confirm it, identify the case patients, and characterize them according to time, person, and place, and also identify exposure and risk factors, and therefore put in place control, and prevention interventions. The methods that we put in place included case definitions, placing case definitions, and our suspected case definition was any resident of Malakal presenting with or dying from acute watery diarrhea from the period 1st of February to 31st of May 2023. A confirmed case was one that underwent culture or polymerase, molecular testing, polymerase chain reaction, and testing positive. We conducted active case search in health facilities and communities, completed case investigation forms, and also line listing of cases. Stool samples were collected, and also we collected water samples for testing and computed frequencies, proportions, attack rates, and case fatality rates. These were our results. Total of 1,458 case patients and 2 deaths were recorded with a case fatality rate of 0.14%. The median age, this was a unique outbreak in that most of the cases occurred actually in the age group below 5 years. As I indicated, 2 of the stool samples tested positive on culture, and one unique thing also was that we identified 901, 90139 serogroup. The epicurve, I will focus on the epicurve. As you can see there, that there were 2 sites, protection of civilian sites. Malakal is one of the areas in complex humanitarian setting, and their displaced populations. So the outbreak was majorly in town, and then a few, of course, cases. Okay, all right, okay. Yeah. In the POC and town, we also did attack rates, and as you can see, the highest attack rate was at the POC. OCV status, unknown proportion was high in, the highest percentage was among the unknown OCV status. All water points were contaminated, as indicated there. Okay. As public health actions, we conducted blanket chlorination of water points. Food and water vendors operations were halted, and also OCV was instituted. As recommendations, we recommended multi-sectoral coordination of WASH partners and also to improve planning and implementation of OCV campaigns. Thank you very much.
Thank you, Joseph. So the last presentation is done. The floor is yours.
Good morning, ladies and gentlemen. My name is Wizon Klenwe, a frontline alumni from Ghana. Kindly permit me to share with you our findings on cholera in the era of COVID-19, a positive trend in Volta region. Ghana is endemic with cholera, with frequent outbreak. In 2014 alone, the country recorded over 20,000 suspected cases, out of which 1,043 cases were confirmed. Unfortunately, we lost 193. Similar outbreaks were observed in Volta region where the study took place. This study sought to look at the cases reported prior to the COVID period and during the COVID period to allow the country put more measures in place to prevent further occurrences. Based on this, secondary data analysis was done for the suspected cases. We also carry out variables that we were able to extract. We extracted age, sex, and place where the cases were coming from. We relied solely on the line list and the DIMS data for our work. Data were represented using charts and tables. This is a map of Volta region showing the 18 administrative districts with a population over 1 million. We found out that most of the cases were reported between the age group of 0 to 4 years, and the female were mostly affected. And most of these cases were also coming from Akachi South, where they have poor sanitation. And then most of the cases were also recorded in 2017 as well. The district that reported the case, the two confirmed cases were Ketu South and Ho Municipal. For the 6-year period, the confirmed cases and suspected cases were reported between 2017 and 2018. From 2019 to 2022, the region did not record any suspected case and confirmed cases. This might be as a result of the 2 cases that were reported in 2018. We put a lot of measures in place. Secondly, we also put in measures in place during the COVID period. And it can also be as a result that the people have shifted their attention from the cholera to the COVID. We therefore conclude that most of the cases were reported between the age group of 0 to 4, and the female were mostly affected. We recommend to the Ghana Health Service to help promotion it, to support the region with a lot of educational materials. To sustain this gain, they will reinforce of the use of hand washing facility and the protocols at all the public health places and the health facilities. There were retraining of additional health staff as well. There's a provision of additional hand washing facility at the vantage point in the hospitals. Thank you.
Thank you, Wisdom. Thank you all our presenters for your very nice presentation. Now the floor is open for questions. I will be very glad if you ask questions to all the presenters. Yeah. So presenters, please take notes of the questions, okay? So please, very specific, when you ask the questions, try to address the specific presenter. So we'll start.
Good morning and congratulations for the wonderful presentations. My name is Stephen from the Zambia National Public Health Institute. My first question goes out to Salime, to Wamaka on the cholera outbreak in Salime. If I heard you right, you had mentioned that this outbreak took place in a fishing village, and one of your findings was that the fishing occupation was associated with this. What other occupations were there in this village, and perhaps could that just be a confounder that this outbreak, the majority of people in this village were actually fishermen? Then my next question goes to Agnes. I think you had said that one of the contributing, in your conclusion, you had mentioned to say one of the risk factors for infection could be the water and access to toilet facilities. I just wanted to find out, maybe I'd missed it, if from the evidence there was any evidence that you presented in your findings which actually associated access to water or toilet facilities to the cases that were detected. Then my last question goes to wisdom in terms of the no cases detected during the COVID-19 period. Could that be due to, is it a true no cases being detected, or was it perhaps some challenges with the surveillance system? And maybe would they look at other proxy indicators like cases of acute watery diarrhea to see if there was a difference in there to actually confirm whether indeed there were no cases detected? Thank you so much.
Thank you.
Thank you very much to the presenters. I join my colleague in saying those were very good presentations. But of course, I have just a comment or two, maybe put a question at the end. To my colleagues from South Sudan, to Agnes and Joseph, can you specify what study design you used? I know from what you presented, but you need to state in your poster what your study design. If you look, for example, at what our colleague from Malawi told us, she told us it's a case control study. And then our colleague from Ghana just told us now that this was secondary data analysis. So if you could please tell us what your study design was. Otherwise, very important study on an important public health matter which still worries us since the time of John Snow. Well done.
Thank you. So we'll go to the presenters. Well, Maka, you have one question. Agnes, 2 questions. And wisdom, you have 1 question. So you will use 30 seconds to answer.
Thank you for the questions. It really shows that you were following the presentation. And the question was whether the study was done in a fishing community, such that the occupation fishing was a common factor. So basically, I would say the study was not done particularly in a fishing community. It was done in Salima district at a health facility, and per the methodology that I presented, we identified the cases from the line list. From there, we followed the controls as their neighbors or relatives. So specifically, the community that we went to wasn't necessarily a fishing village. However, we did find other occupations in the study population. And when we did the analysis, it still came out as the fishing community as more associated than the others. So there's a manuscript that is available on the same that maybe you may wish to read more. Thank you.
Thank you very much, Brad Steven, for your question. You want to find out whether it's a true case that we didn't record any case between 2019 to 2022. Okay, I said it in my submission that the zero reporting might be as a result of the measures we put in place during the 2018 where we had an outbreak. We put a lot of measures in place during that time. So those measures were sustained before the COVID came in. And secondly, I said it might be as a result of COVID measures be put in place. And thirdly, it can be as a result that most of the districts have shifted their attention from the cholera to the COVID. Thank you.
Thank you for the questions. Concerning the drinking water to the community, as we know, staying in IDPs is not an easy thing. They have the common source of water where everyone is getting water from there. And the picture for the latrines, I see it is there in the presentations, showing the hygiene situations of the latrines facilities in the IDP. Thank you.
Okay, thank you very much. I think there was one question to both of us, I think, which is common on the study design that we put. Yeah, I just forgot to mention right from the outset that this was a descriptive study. And initially, of course, when we submitted the abstract, it was when the outbreak was ongoing. And when we concluded, of course, with the outbreak, we had to update our data, and it also involved actually secondary analysis of data. So thank you very much.
Thank you. Thank you, our presenters. Congratulations on your achievement. Well done job. Thank you. Please give a round of applause for our presenters. Yeah, you can take a seat. So I will call the next round of poster presentation presenters. So Wayne Coney, Beatrice, Chika, Bilikisu, Albert, and Nalidi. Chika, are you around? Chika and Albert. Chika, Albert. So if they are not around, we will continue our session with the presenters we have in the podium. So I will give the first floor to Mendoki. Yeah.
Oui, Wayne Coney.
Yeah.
No, Tugma. T-O-U-G-M, yes. It is.
You know how to navigate. You know how to navigate.
Yes. Okay, merci.
All right, thank you very much. My name is Dr. Tugma from Burkina Faso, FETP. I have the great honor this morning to present to you the results of our study that was about the epidemiological profile and the associated factors to the diarrheas for rotavirus in the health centers in the region of Gawa in Burkina Faso from 2013 to 2022. So the diarrhea of rotavirus are actually the ones that cause more than 200 deaths in the world. And most of these deaths is in sub-Saharan Africa. Rotavirus actually are part of a surveillance since the introduction of the Rotatec vaccine in 2013 in Burkina Faso. And the incidence of this diarrhea was about 72% in 2016, according to Kabwe studies. But up to date, no studies have been done about the importance in the sentinel sites in the regional center of Gawa. And that is why we have this study that has as an objective to analyze the various factors associated to this diarrhea of rotavirus in Gao. And we've adopted this following methodology when we had a cross-cutting and analytic study from 2013 to April 2020. And we analyzed all the suspected cases that have been captured in the database, and we had about 1,800 cases. And the data were collected through the various collection files. We considered our population, all the children that are less than 5 years who are actually hospitalized in the health centers in Gawa for acute, chronic, and diarrhea in the period of the study. We excluded all the diarrhea cases for more than 48 hours and were in another site. And the extracted data were analyzed with APN4 Strata software. And for the mapping, we did a chi-square test, and we had associated factors for the prevalence, and there was a trust or the confidence about 95% when we did this test. So, ladies and gentlemen, this is the map of the southwestern region in Burkina Faso. And those are the different points that you can see that. Those are the training centers. And the central point is actually Gawa.
En termes de résultats, il faut dire que
as regards results, we must say that in the database we found 1,800 cases registered, and among those, 98% of data was missing, and we didn't find any outrageous data. We didn't find any files that were incomplete that would stop us from taking this study. And we included 1,773 cases with a median of 6 months. The prevalence of the rotavirus in our study was 22.6%. For analysis of factors related to the rotavirus diarrhea, this table summarizes those results. You can note that rotavirus diarrhea had 8 more chances of returning in the dry season compared to the wet season. The same thing applies to the level of education of mothers, which was associated to the return or survival of the rotavirus diarrhea. Ladies and gentlemen, we can note that rotavirus diarrhea constitutes a real public health problem in Burkina Faso, particularly in the southwestern region. The dry season and the level of education were associated to the rotavirus diarrhea cases, and preventive measures during the dry season would be one of the solutions to fight against rotavirus diarrhea. Thank you very much for your attention.
The next presenter will be Beatrice.
Bom dia.
Good morning. My name is Beatrice Viantumbo. I will present in Portuguese. I will talk about the system of diarrhea in Nampula province in Mozambique in 2019-2020. Diarrhea happens in Mozambique, which is considered as the 4th cause of mortality, especially in the south part, as objective of the studies to evaluate the system of health in the province of Nampula in 2019-2020. Evaluation was based in the updated guidelines from Africa CDC from January 19 to January 2020 as data, we use investigation. Now, we also evaluated the representativity and the quality of data. As a result, the flow of information initiated, the data was collected from the registers according to epidemiological aspect. We went to the districts and we collected the messages and we introduced it in the system. Also, we used the automatic system in the health centers and also in the Ministry of Health. Now, we collected information from the Ministry of Health and also the health centers. Now, we treated cholera-associated diseases. As a result, the results were obtained from 2 to 5 days. Now, we used the simplicity in our evaluation. We evaluated the different variables. We used a lot of instruments and also information. We also considered different other systems of surveillance. Now we have 2 variables, 3 levels of information, using also online system and also other systems of information which are simple. In terms of the quality of data, we considered the age in the district, the city, the estate, and also the date of the beginning of the area. And also we considered the age between
in terms of the registration, these are the results. We realized that this was 5.5. The representation in of diarrhea, we realized that there was an analysis of time with the represented group. We realized that it's important to have surveillance in order to realize the magnitude of the disease in the country, and it's important to have the correct collection of data. Since we recommend that we continue with the monitoring and the collection of data from all the public institutions in order to be able to monitor the situation. And this is the picture which shows that some of the investigations that we took. Thank you very much.
Thank you, Beatrice. The next presenter will be Palekiso.
Profil épidémiologique. Yes. Bonjour, chers tous.
Good morning, everybody.
Okay. Bonjour, chers tous.
Good morning,
Nous,
everybody.
Nyonyo
FTP,
Bénin.
I'm FLTP resident in Benin.
Le profil épidémiologique
So, I'm going to present you the epidemiological profile of cholera in Benin between the years 2020 to 2022. In that direction, shall say that cholera is a waterborne disease which is provoked by growth in Vibrio cholera places. Every year, it affects between 3 and 4 million people through the whole world, with about 21,000 deaths. This is a real public health problem in sub-Saharan Africa, of which is Benin. The Atlantic district is one of the most affected districts, and the objective of our study was to establish the profile of cholera cases in the Atlantic district. Method. It is the district of the Atlantic which was the point of interest of our study. So this is the coast zone of Benin. So there's a commune which is near the lake here, as you can see, which was most affected. Type. So we made a type of population was transversal from the year 2007 to 2021. The source of data was the SNA, Integrated Surveillance of the Disease, and the Departmental Center of Health of the Atlantic. We expected the data from those bases, and we refined it. And we looked at all the registered cases. Data analysis was done by Info7 and SN programs. This enabled us to look at absolute and relative incidence. And in that program, we used F6. The results. In total, 153 cholera cases were registered in the district of Atlantic from 2015 to 2021 with 0 deaths and 25 cases confirmed. That's about 14.91%. The majority of the cases, that is 43%, 93% were coming from rural areas. The age bracket was between 15 and 21 years with 42%. The ratio of man to women was 1.19, 1.1 to 1.59. This figure here shows us the distribution of suspected cases and confirmed cases in the Atlantic Department or the Atlantic District from 2017 to 2021. Well, the epidemic of cholera was more pronounced in this Atlantic district. And in 2021, we notified an epidemic of big size. This figure here shows us the distribution of cholera cases according to the origin of the people in this district. All communes almost notified at least a suspected case of cholera, except the Toribosito commune. The lake commune of Siava notified the most of cases in its district. In conclusion, we shall say that cholera is mainly among the men and in certain periods of the year. An intensification of prevention measures in rural areas, and for the third term, the third quarter will help to reduce its incidence. We cannot finish our work without thanking our mentors and STP coordination, CDC of Benin, and partners CDC Atlanta, AFENET, and our country Benin through the Ministry of Health, and the Republic of Kenya, which has hosted us here. I thank you very much.
Merci.
Thank you.
will be Nalida. Nalida, the final presenter.
This last one.
Yeah, this one. Nalida, you have 5 minutes, okay? 5 minutes.
Yes.
I will let you know when you're running with 1 minute.
Okay.
Do you know how to navigate? Okay.
Yes. Good morning, everyone. My name is Naledi Mapita, and I'm from the South African Field Epidemiology Training Program. I'll be presenting a foodborne disease outbreak investigation that happened at a community hall in Soweto in October 2022. So foodborne diseases caused by the ingestion of food contaminated by microorganisms or toxins, and the WHO approximates that 1 in 10 people globally are affected and 92 million Africans are affected yearly. Symptoms include diarrhea, abdominal cramps, nausea, vomiting, and fever. On the 10th of October, a fire broke out at a squad camp in Soweto and affected families sought shelter at a community hall. NGOs and neighbors donated food to the affected families, and on the 12th of October, residents complained of abdominal cramps and diarrhea. The outbreak was notified on the 13th of October. This is what a squatter camp looks like, and this is a map showing South Africa and Gauteng province. We investigated the outbreak to confirm the outbreak and to determine the magnitude and the cause of the outbreak, as well as to institute control measures and recommendations. We conducted a cross-sectional study using standardized questionnaires, and food consumption history was collected through interviews. A case was defined as a person residing or eating at the community hall from the 10th to the 12th of October and presenting with gastrointestinal symptoms. Rectal swabs were collected to test for enteric pathogens, and we assessed the surrounding area of the community hall. Statistical analysis was done through logistic regressions to determine the meals associated with illness. We found that approximately 70 people resided at the community hall and 22 people were interviewed. Of these, 82% reported illness and 73% of the cases were female. The median age was 22 years old and ranged from 0 to 44 years, and the most common symptoms were diarrhea, abdominal cramps, and loss of appetite. The distribution of cases shows that most people fell ill on the 12th of October around 2 o'clock. The rectal swabs collected tested negative for enteric pathogens, and toxins were not tested. Our environmental findings show that there were no refrigerators at the community hall, and some meals were prepared and donated by members of the community whose food safety practices cannot be ascertained. Meals were not consumed immediately after preparation, so we cannot say how leftover meals were handled. Our statistical analysis showed that supper served on the 11th of October showed the highest odds of illness and in those who ate, and this supper consisted of biryani, rice, chicken, and cabbage. The rice showed the highest odds of illness in those who ate, even though the result was not statistically significant. These pictures here show our environmental findings. This was the community center. This was the bathroom or the toilets that they were using. And this is the hand washing bucket that was placed outside the toilet. And finally, this is the food preparation area. Although the clinical samples tested negative for enteric pathogens, we speculate that this outbreak was likely due to contamination of food with toxin-producing bacteria such as Bacillus cereus. And unsafe storage of cooked rice has been linked with growth of toxin-producing bacteria. We recommend that appropriate and sanitary hand-washing amenities be provided, food handlers be trained on food safety practices, and a fridge be acquired for proper storage of food. Our public health actions included providing sanitizers and soap to the residents, and we address the residents on food safety, hygiene, and frequent hand washing. We also appointed specific people to serve food at the community hall, and new shacks were donated to the residents. Thank you.
Thank you, Naleda. Thank you, all the presenters. Now the floor is open for questions. We'll be very happy if all the presenters receive at least one question. Okay, let's start. Yeah.
Yeah, thank you very much for these great presentations. I'm Alex Bolo from South Sudan with the CDC. My question goes to the presenter that just gave us the outbreak of, that is Guateng. How was the selection for the 22 people who were interviewed and rectal swabs were taken? What was the determination for those people? And then secondly, I did not hear of any stool testing being conducted. Why was it excluded if it was not done? I also wanted to ask when Kony, who presented from Burkina Faso on rotavirus, I would like to know why there was exclusion of some cases from one of the facilities, one of the sites, where the area cases were reported for more than 48 hours. What was the reason for excluding those ones? Thank you.
Thank you. Is there any other question? Yeah, Carl, please.
Thank you. Thank you for the opportunity. Carl Reddy, AFENET. A question for Wen Kuni. How will you use the results of your study to motivate for rotavirus vaccination, for routine rotavirus vaccination at the beginning of the dry season? And then a question for Naledi. I'm not sure if the previous questionnaire asked this, but can you just maybe tell us if there was a challenge getting rectal swabs? I noticed that there were 22 only. And how did you deal with this challenge? Thank you.
Thank you, Carl. Please.
Just a brief question again. Excellent presentation. Reginald from Zimbabwe. Naledi Dumela, a quick question to you. When you showed us the pictures about the hand washing, I saw one bucket. Were people communally hand washing in that bucket, or there's a tap-like system? And then to Beatrice, muito obrigado. Excellent presentation. I just wanted to know, this was not your post, I know, but are other provinces beyond Nampula also using the same surveillance system, and can they learn from Nampula?
Thank you.
Merci à tous pour le bon rapport.
Thank you very much. Asking the Benin lady, you didn't tell us what are the health, public health action which has been taken, and what are the recommendations for the future?
Thank you for all the questions. I have one question for all the presenters. My question is, what was your motivation to conduct the study? So I will give the floor to the presenters to address questions relevant to your context. Yeah, I will start from Naleda.
Thank you very much for the questions. So I think it was Alex asked how the 22 people were selected. So when we went to the community hall, we found that approximately 70 people were residing there. However, during the day, they move around, so they don't stay at the community center the whole day. So when we got there, we found that a lot of them had either gone to work or to school. So these were the people we were able to sample. And then this question is related to what Mr. Carl already had asked about challenges getting participants. So that was the challenge. And we dealt with this by trying to get their phone numbers so that we can contact them. However, there was a fire, so a lot of their burnings had burnt in the fire. So yes, we tried to get the contact numbers of people who we could get, and also try to ask them to give each other the phone so that we could interview them. And then back to Mr. Alex, you said why were the no stool samples collected? So they refused, some of them refused to give us a stool sample, and some also said that there was nothing to, like excrete. So because they had so much diarrhea. And the question from the gentleman from Zimbabwe about hand washing, yes, everybody was washing their hands in that very same bucket. And to answer the moderator's question, motivation to conduct the study, this was an outbreak, and the people who were at the community hall were, the people who were at the community hall were displaced people. So we wanted to get there and also help them and find out what the cause of the outbreak was. Thank you.
Merci. Et la question,
Thank you. The question was to understand what public health action we have taken as the recommendation for future. I think when we did our study, we did share a finding with the health directed department. So when we share this finding, it's at that level that they will come up with action to come up with a preventive measure. And I've said it in our conclusion. So I said that they need to treat water and then have the wash program, and of course washing. So those are the actions which will be taken.
The surveillance system, it is in the whole country, in all of Mozambique. They all use the surveillance system. In terms of assessment of the system, Nampula is a province where a lot of cases happen, cases of diarrhea, and so it was very important to conduct this surveillance in that very province. Thank you very much.
Merci à tous pour l'ensemble des questions qui témoignent.
Thank you very much for all your questions. It means that you are very interested in our work. For the first question of Mr. Alex, you should know that the rotavirus affects children of less than 5 years than adults. So the second question is that the database that we did use was mainly for children under 5 years. That's why we focus on this group. And if there were errors where we register adults, we just remove them. So to answer the second question, the use of our data, you note that the study is a very interesting one because it shows the period where the rotavirus diarrhea happened. Once we understand the period, it will be easy to do an advocacy with the Ministry of Health as well as the direction of prevention, so that we can come up with a vaccine campaign in order to prevent the disease during that period, because this virus is very dire. So, about motivation, why did we decide to conduct the study? As I said, it's an issue of public health, and at that time I was responsible for the fight against this disease, and we did notice that we didn't have enough data, yet we do have a lot of diarrhea cases, and then that was our motivation. So the second point is that we did introduce a vaccine which was very efficient, but despite that, the vaccination, we still have cases of rotavirus. That was what motivated me to do the study. Thank you very much for all your questions. I hope that I did answer to your question. Otherwise, we can still talk about it in the corridor. Thank you.
Thank you all our presenters for your wonderful presentation. I hope your study will have impact in improving the public health practice of your country. So once again, congratulations and well done job. Thank you. Please give a round of applause for our presenters. You can take your seat. So with this, we will end our session. So I will hand over it to the next session. Thank you so much.
but this session is directly linked with the theme of the conference, which is strengthening public health systems in Africa towards enhanced global health security, the role of FELTPs. So our speakers this afternoon, we have an illustrious panel of speakers. It is my intense pleasure to be the moderator this afternoon, and our speakers will take us through their unique perspectives of global health security. Without further ado, I'd like to introduce Professor Adebola Olayinka, who is currently a consultant with the World Health Organization, AFRO, working to support various countries in the region in emergency preparedness and response. Prior to this, she had been IPC focal point and research officer with WHO Nigeria, and also coordinated research on Lassa fever for the Nigerian Center for Disease Control. She was senior technical advisor to the DG NCDC and had also worked as laboratory resident advisor to the Nigeria. Adebola Olayinka is a professor of medical microbiology. She's board chair and chair of the Education Committee of the Infection Control African Network, the board of Center for Infection Control of Patient Safety, and PI for some AFENET projects. A warm round of applause for Prof. Adebola, please.
Good afternoon, everyone. So I'll be talking about strengthening IPC in African health systems towards global health. And I think here I need to tell you what IPC is. There was a time I was giving a talk, and after a few minutes, someone raised their hand and said, please, what's IPC? And said, I thought it was interpersonal communication. I also found out that IPC could stand for Indian Penal Code. But today we are talking about infection prevention and control, and that's what the IPC stands for. So I'll start, by just reminding us what IPC is. Many times when people talk about IPC, they equate it to hand hygiene and maybe the use of PPE, which is an aspect of it, but beyond that, it's actually a practical and evidence-based approach that prevents harm from avoidable infections. And that tells us that we have some infections that are avoidable. The other thing IPC does is it protects the patients, it protects the healthcare workers, and then it protects anyone who visits the healthcare facility for anything. Let's also remember that in the world of antimicrobial resistance, and also with epidemic-prone and pandemic-prone diseases, IPC plays a critical role. It helps to prevent and stop the spread of diseases. When we talk of emerging new infections, some of these infections will emerge, whether we like it or not. The recent COVID was one. But what we want is that we want to limit the spread. We want to minimize the risk of transmission, and IPC does that for us. And so for IPC, it's critical that we understand how transmission occurs. It's critical we understand what we can do to prevent transmission, whether it's from a recognized or an unrecognized source. And then we also need to know what principles we can use within the community to prevent these infections. So coming to global health security, we have different contexts. But in Africa, we know the kind of context we are dealing with. We have issues with urbanization. We have issues with population growth. We have issues in terms of globalization of travel and trade. and politics, pollution, climate issues, and so on and so forth. And of course, the fact that organisms are mutating, and with this mutation, we could expect anything. Now, Global Health Services talks about the existence of strong public health systems and about whether we can prevent the emergence and the spread of these diseases. We can't talk about public health systems that are strong and resilient if there is no IPC component to it. And the recent outbreaks we've had in recent times, when we talk about the Ebola, Marburg, COVID, has really brought to fore the need for IPC systems. So IPC goes beyond just an outbreak response. It's a response, it's relevant in outbreak response, but in terms of health system strengthening, IPC is critical. So there's the proactive, which is the preparedness and readiness component, and then there is the reactive part, which has to do with outbreak response and ensuring that we provide safe care. So when we normally talk about public health response, we talk about 4 areas. We talk about prevention, detection, response, and recovery. And IPC has a role in all those places. In terms of prevention or preparedness, we are talking about having the systems, having the plans, the trainings, the capacity building. And these are things that need to be done IPC-wise as part of preparedness for epidemics or preparedness for public health events. We need to be ensuring that our IPC systems in our countries are ready. Once detection has happened, the next most important thing is how is this disease transmitted? Because if we do not understand how it's transmitted, we cannot control it. We cannot put in appropriate control measures. And IPC helps us in terms of the mode of transmission and what you do to mitigate against this. In response, a critical aspect of response is providing care for those who are affected. And that care must be safe. And in the process of providing care, you want to protect the healthcare workers, you want to protect other patients. And IPC is crucial in ensuring this. And then for recovery, the outbreak is getting over. You want to strengthen the system to ensure that we can move forward on this. So this year at the World Health Assembly, there was a new, before the World Health Assembly, just going back to IHR 2005, and looking at the JEE tool, the Joint External Evaluations tool, there is a new edition, the 3rd edition. And one of the major differences in this 3rd edition is the fact that IPC was brought out as a core technical area by itself. Before, it used to be an indicator under antimicrobial resistance. And this revision is important because the new tool was expected to improve the quality of assessment of the public health system within countries. And it came out that IPC was critical. It couldn't just be an indicator under AMR, but it needed to be a technical area by itself. And R4 tells us that it's important for countries to have strong, effective IPC programs that enable safe health care and during essential services delivery. So the R4 has 3 indicators. It's looking at IPC programs, nationally, subnationally, and at facility level. It's looking at surveillance for healthcare-associated infection, which serves as a proxy to how effective IPC is functional within the system, and also ensuring that our health facilities are safe in terms of the environment. So this is telling countries that as much as we have IPC as part of emergency response during outbreaks, either epidemics or pandemics, we need to have IPC programs for health system strengthening in terms of preparedness, and more critically, in terms of readiness. Now, COVID has taught us that it's not just enough for countries to be prepared. Countries need to be ready. And for emerging and new emerging infectious diseases, countries need to be ready IPC-wise. I'm just showing a timeline on how the IPC program and its implementation has progressed over time. In 2009, the concept of, clean hands save lives, that put a lot of focus on hand hygiene. And then fast forward a bit to 2015 when the injection safety policy came up. And by 2016, then we had the core components which were defined for an effective IPC program at the national level and then at the facility level. Then by 2019, it was found out that a lot of countries, especially developing countries, Africa is a key one for this, we are not able to meet up with those core components. And so there was a definition of what was termed minimal requirements, that, okay, if you could not achieve the 8 core components for IPC programs, you should at least aim to meet up with the minimal requirements. And then by 2021, 2022, with COVID and then with other public health emergencies, the development of operational frameworks and toolkits for IPC came up. And then this year, there was the global strategy on IPC, and for the first time, there was a research agenda, even though it was limited to hand hygiene, but it's a step in the right direction. So I'm going to give you a brief overview. What is this global strategy all about? The global strategy on IPC. It was, like I told you, was Resolution 7513 at the World Health Assembly this year. And it's really focused on improving IPC at national levels, at sub-national levels, and then at facility levels. So it provides quite a number of things like the business case, the strategic directions, and effective approaches that countries could use. And it also anchored IPC in the context of health system strengthening and also in the implementation of IHR 2005. So it focuses on IPC in any setting where healthcare is delivered, and then it also highlights the central role of IPC in combating antimicrobial resistance and also in outbreak preparedness, in outbreak readiness, and in outbreak response. And it has all those aspects to it. But in the next slide, I'll just briefly acquaint us with what's the vision and what are the key objectives. So the vision is that by 2030, everybody should be able to have access, and every healthcare provider should be able to provide safe healthcare. So it's really providing safe healthcare at all levels. And the objectives are, one, to prevent. We want to prevent infections in healthcare. We want to prevent avoidable infections in healthcare. The second is acting. So it's for nations, it's for hospitals, it's for lower administrative areas within countries to act to ensure that IPC programs are in place. And then the third talks about coordination. If you've been in the public health space for long, you know that there are various aspects, and there's a lot of cross-cutting issues. Talking about WASH for antimicrobial response, for antimicrobial resistance plans, either at global or national levels. IPC is a critical aspect of those plans. If you're looking at immunization programs, you're also looking at biosafety principles. All of these have some principles of IPC within them. And so within countries, there must be a coordination of these various players to ensure that people can have access to safe care and healthcare workers can provide safe care by 2030. And just a brief on the research agenda for hand hygiene in healthcare settings. That agenda is 2023 to 2030. A Delphi process was used to obtained 21 high priority statements that's across the 6 domains of hand hygiene. And we have the 6 domains put there. You can always get the details of this online. So as I'm rounding up, I'm bringing everything home. So we've talked about the global strategy. We are talking about the research agenda. We are talking about the vision for 2030. We are talking about preparedness, readiness, and response for emerging and new emerging threats. But coming down to Africa, how do we strengthen IPC in our African health systems? From the global strategy, there are about 8 expected country actions that will help countries to implement the global strategy for IPC. And one comes up, which is political commitment and the policies. And I'm sure you'll agree that this is very critical. One of the things that has been found out is when there's an outbreak, there's a whole lot about, oh yes, let's wash hands. You'll find hand washing stations almost anywhere you go to. But once the outbreak has died down, nothing happens. We go back to status quo. And this is where political commitment and policies are really relevant. Currently now in Africa, there's a lot of cholera. Some countries call it acute watery diarrhea, either because they're not testing deliberately or otherwise. But one thing is that if hand hygiene was being practiced, will actually reduce the incidence of diarrheal diseases. And this has been proven. The other thing is that countries are expected to have IPC programs at the 3 levels I mentioned, nationally, subnationally, and at facility level. And then IPC integration and coordination, I think I talked about that. The 4th is the knowledge of healthcare workers about IPC. I've attended a few IPC sensitization workshops, and I know there's a whole lot of emphasis on putting on the PPE, the full body suit. It's good for some diseases, but we actually need to be looking at the basics of standard precautions. So there is a lot for countries to do in the African setting on healthcare workers just being aware, what are the basic components of standard precautions, how do we implement this, and when do we use the transmission-based precautions. Then the other part is that currently in the region, there is no career pathway for IPC professionals, and that is limiting. Then data for action. In the region, we do not have IPC data. I don't know if there's, well, maybe a few countries might have, but I can tell you that probably 80% or more countries do not have IPC data in their national health information management system. And then we have to continue with the advocacies, with the communications, research and development. And this is a challenge in Africa. I'll say this later. And collaboration. So let's look a bit more closely at the challenges we face in the region. Some countries have IPC policies. Some have, and it's not implemented. It's just a document. Funding. IPC programs need to be funded. Some countries have IPC programs, but there's no funding. Technical expertise I talked about, systemic and structural challenges, the way some of our healthcare facilities are built, even having that system in place. And then this critical one, inadequate technology and development. If Africa has to depend on importation of PPE for all the health facilities within the region, we'll not be able to practice IPC as it needs to. And then data and research on IPC. So this is my last slide. And my key messages are that for us to achieve global health security and universal health coverage, IPC is critical. And like I mentioned, it needs to go beyond outbreak response. It needs to be systemic. It needs to be structured. For Africa, political commitment, integration within our health system, and the general coordination is a critical aspect. And finally, for research and development, we should be able to produce our own PPE to ensure that our healthcare workers are able to provide safe care. Thank you.
Thank you very much, Professor Olayinka, for that illuminating panorama. Thank you. It's my pleasure to now introduce Dr. Curtin Victory. Dr. Curtin Victory is the Regional Global Health Security Advisor for West Africa in CDC's Division of Global Health Protection and Commander in the Commissioned Corps of the U.S. Public Health Service. Commander Victory has contributed immensely to global health security work in West and Central Africa, including providing technical support for Ebola and cholera preparedness activities, for Crimean Congo hemorrhagic fever and Marburg virus disease outbreaks, and strengthening the regional public health systems to respond to future infectious disease threats. Prior to his post in Nigeria, Commander Victory served as a senior supervisory emergency public health epidemiologist on CDC's Global Rapid Response Team. He began his career with CDC in 2014 as an epidemic intelligence officer. Commander Victory received his MSc in nutritional sciences and his PhD in environmental health sciences from the University of Arizona. And I will include something that he struck off. In his spare time, he enjoys traveling to different countries, hiking, and experiencing different cultures. A warm round of applause for Commander Victory, please.
Okay, good morning, bonjour, bon dia.
Good morning.
Is of West Africa. So my presentation for today is Global Health Security Agenda in a Post-COVID-19 Era. So what is global health security? And overview is CDC Global Health Security core areas that we support, assessing global health security capacity and performance post-COVID-19, areas for strengthening health security architecture, and conclusions. So existence of strong and resilient public health system that can prevent, detect, and respond to infectious disease threats wherever they occur is primarily the core area of global health security. CDC primarily strengthens capabilities in these 4 areas, including laboratory systems, surveillance systems, workforce development, and emergency management. So capacity building addresses global health threats at the source and the primary core for global health security. This requires efforts by all countries at national and local levels to stop outbreaks, including programs providing technical experts and contribution to global guidance and efforts. How do we assess that? We use capacity and performance to review and to assess global health capacities in countries or regions. So global health security post-COVID-19 reviews of global health, review of the global COVID-19 response allow us to assess what was effective and what was not. So again, using examples of countries, for example, pre and post-COVID, assessing what are the gaps, using AARs, after action reviews, GEEs, to strengthen those capacities in country and regions. Also, issues that impede are more effective for global response. And last but not least, lessons learned will help guide the future of global health security. It is noted that capacity does not mean performance. Many countries' performance during the COVID-19 pandemic did not match their assessed capacity. Capacity assessments are also useful to proactively identifying gaps, planning improvement across technical areas as well, but are less useful for predicting performance. This underscores the importance of pairing capacity and performance in assessments. So, looking at COVID-19, highlighted capacities that were underemphasized or absent COVID-19, capacities that were more emphasized, again, by partners, and that was reported from AAR after action reviews, as well as GEE, supports that we focus more on health services provisions, infection prevention and control, as previously presented, legal preparedness, immunization systems, surveillance and border health, risk communication, and human resources. I highlighted immunization systems since this is an African conference to stress the importance of immunization within the region. The impact of pandemic and disruptions to vaccination on infectious disease epidemiology is important and also lessons to be learned. COVID-19 disrupted routine vaccination programs, and recent floods have contributed to increases in cases of diphtheria and cholera globally. This is a snapshot of the Afro-WHO newsletter showing new cases of cholera in Africa surging fast, reaching a third that was reported in a month compared to the whole of 2022. Again, lessons can be learned. For example, during floods, access to routine vaccinations can sometimes be disrupted due to inaccessibility of roads and logistics. Also, floods can also bring waterborne diseases such as cholera. This stresses the importance for the African continent to make sure that immunization systems are strengthened for future pandemics. How do we integrate capacity and performance? Efforts are underway by WHO with CDC support to provide guidance to countries on how to effectively integrate performance assessments. Lessons learned from these assessments will be used to build global health security capacity in countries and regions. However, looking at the backbone of global health security, how do we strengthen health security architecture? Looking at the gaps identified from COVID-19, it is clear how many countries coordinate, share important reports, outbreaks. Somehow, these have been lacking. COVID-19 highlighted that we still lack critical tools and accountability to measure to assist countries in reaching compliance with international health regulations. Hence, it is critical that we learn to amend IHR to address some of these to include issues that were previously identified in after-actions reviews and noted in previous post-pandemics. Health security is not possible without health equity. There are still vast disparities both between developed and developing countries and within countries in terms of who experiences the high burden of diseases and who have access to health security. CDC, the Centers for Disease Control and Prevention, states that health equity is achieved when every person has the opportunity to attain his or her full health potential, and there is no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. If you look at this image, this well depicts the difference between inequality. Think of this as country A or country B. For example, $500,000 is given to both countries to support global health security work. Keeping in mind that some countries do not have the infrastructure and may not be able to meet those goals as seen in the picture where it's inequality. Equality tries to address that while providing additional resources to help countries meet the need. Again, you can see that country B gets closer in this example, but again, there is still not leveled equality. In equality, as you can see, we provide additional support, for example, in global health security priority countries, for countries to meet certain targets. And last but not least, it's justice when you're able to fix certain systems to make sure that everyone in countries have equal access across the board. This slide shows US funding for global health security for fiscal year 2023 to 2013 to 2023. The dark blue represents global health security co-funding. The light blue represents emergency Ebola. Dark green, emergency Zika, and light green, emergency COVID-19. Generally, global health security funding from US sources has been steadily increasing over the past 10 years. However, as you can see, funding is more reactive. For example, during the 2014-2015 DRC Ebola outbreak, you can see a substantial increase in global health security funding to support many of the outbreak response and recovery efforts. Same as in 2016 for Zika, and then 2018 DRC Ebola response. And of course, we cannot forget the COVID-19 pandemic, which affected multiple countries across the world. However, although funding has been steadily increasing, several studies have estimated a $10+ billion gap in resources for global health security. The cost of pandemics far exceed disinvestments. Even the cost of local outbreaks on the continent far exceed that. Most recently, outbreaks in the Republic, the Marburg outbreak in Equatorial Guinea, and also for preparedness efforts in neighboring countries such as Gabon and Cameroon. The United States, including the US Centers for Disease Control and Prevention, has prioritized support for the pandemic fund. This direct stream of resources that countries can utilize to improve pandemic preparedness and also have many of the same capabilities of global health security. So in conclusion, I would like to say global health security after the COVID-19 pandemic is more holistic, more multi-sectorial, and an issue for government and not just ministries of health and agriculture. How can this be achieved? Through effective partnership. So effective partnerships are critical for attaining and sustaining progress. Looking at global and not local, global is local. Global public health and local public health are strongly linked. Hence, we work with local authorities to make sure gaps are identified at regional and sub-regional levels, and also locally to make sure any districts or prefectures where gaps are identified, those are strengthened to make sure that we are building a solid system from the ground up. Measurable target, as I mentioned before, using capacity and integrating that to performance to make sure that we are building stronger, resilient, more public health system to respond to future infectious disease threats in Africa and other continents across the world. These are the references. Acknowledgement to the speaker, Mike Mayer, who was supposed to give this presentation but was unable to make it, and also from CDC Nigeria and US CDC West Africa Regional Office. Merci. Obrigado. Thank you.
Thank you very much, Dr. Victory. And the third and last speaker for this morning's session is Dr. Penina Munyua. But before I introduce Dr. Munyua, I would just like to remind you to please formulate your questions, so at the end of the third presentation, we are able to take those questions. So Dr. Munyua is an infectious disease epidemiologist and senior public health specialist at US CDC's Global Health Center, Division of Global Health Protection in Kenya. She has over 15 years of experience in public health research on infectious diseases in population-based and facility-based platforms. She has extensive experience on public health system strengthening and establishment of infectious diseases surveillance systems, setting up platforms for implementation of One Health in Kenya and the region, capacity building for outbreak response capacity, and development of disease preparedness and control strategies. She has contributed and participated in translation of research findings to strengthen public health systems. Welcome, Dr. Munyua.
Thank you. So good afternoon. First, I'd like to thank the AFENET team for putting such an impressive conference and also inviting CDC Kenya to come and share our experience. I was going to talk about, I don't know whether the slides have come up. I was going to talk about CDC's efforts towards global health security strengthening in Kenya, but based on the two presentations before me, I could safely reward this to how do we strengthen health security at source, because what I'm going to talk about is really focused on what we have done in Kenya. I will not talk about global health security because this has been covered by my two previous speakers, but I will say that one of the things that has been emphasized is the need for preparedness, surveillance, rapid response, and also international cooperation. COVID taught us that a disease anywhere in the world is a disease threat everywhere in the world. And there's need for multi-sectoral approach because we have a diversity of global health security threats that we are always dealing with. I will also not talk about the global health security agenda because that has been covered really well. And I will turn my attention on what we are doing with the Kenyan government, the Ministries of Health and other partners. We do work in the four main core areas that the previous speaker just talked about. We strengthen surveillance to quickly detect any outbreaks before they spread. I will highlight some of the programs that we are implementing. We build laboratory capacity to detect, characterize pathogens of public and global health concern. And I will describe the two main approaches that we do use. And then, of course, I'll bring back workforce development, not because it hasn't been covered very well, but because it's one of the programs that I think has been really impactful in this country. And then we do emergency management systems to coordinate effective response activities when crises occur. We are most known for standing up county and the national EOC in Kenya, but we do also do work on IPC and WASH, and also support surveillance at the points of entry. But underlying all this, we recognize the importance of strengthening information systems, and we do have some of the programs that we are currently implementing with the Ministry of Health. We recognize the value of partnerships, the fact that all this has to be informed by science, not just science happening elsewhere in the world, but science that has been conducted in our system, in our setup, and also monitoring and evaluation of the work that we all do. So in terms of partnerships, CDC works globally to leverage collective expertise of many stakeholders, leverage the resources, insights, and also fostering more comprehensive and effective response to the complex global health challenges that we deal with. In Kenya specifically, CDC has partnered with the Ministry of Health for over 40 years to strengthen public health systems, and I've had the opportunity of working with CDC for those 15 of those years. And recently we had an opportunity to document how we adapted our long-standing public health collaborations with the government of Kenya in response to COVID-19 pandemic. But we also partner with the Kenya Medical Research Institute, which is the premier research institute for public health in Kenya, for clinical research and also implementation science. And I'll describe one of the programs that we have been implementing for that period of time. So what we have learned is that to achieve our goals and for us to be able to achieve our goals towards health security, we do have to sustain and we have to strengthen these relationships in the countries where we work. In terms of laboratory capacity, we do this in two main approaches. One of them is we support the Kenya Medical Research Institutes in two of their laboratories to develop and maintain world-class capacities for public health surveillance and research. And I'm happy to report that two of our laboratories are two of the 5 that can sequence SARS-CoV-2, and since the pandemic started, we have sequenced over 1,000 SARS-CoV samples using Sanger and Illumina and shared these sequences with the global health community. And when we are called about by the national government and also by the counties where we are present, we test and confirm approximately half of the disease outbreaks per year. Most recently, there has been outbreaks of E. coli, Pseudomonas aeruginosa, dengue, and also S. typhi and others. We work with the Ministry of Health to capacity build for national and also regional or county laboratories. And the National Influenza Center was a flagship program which has supported influenza sentinel surveillance since 2006. And during the COVID pandemic, we were able to stand up SARS-CoV-2 testing very, very quickly in the country. Somebody did say earlier on, I think yesterday, that for countries that were already doing influenza sentinel surveillance, they had a head start in terms of setting up their SARS-CoV-2 testing. And then NIC in Kenya, which is run by the Ministry of Health, coordinated SARS-CoV-2 testing for the entire period of the pandemic. But we also do build capacity for AMR surveillance, enhancing biosafety and biosecurity, and also setting up sample shipment networks for early detection for rapid response. We have 3 main surveillance platforms that we do implement, and I wanted to show it in the pyramid form for 2 reasons. One, to show our level of involvement, which is important, but also to indicate the geographic coverage. So I'll start from the bottom. At the bottom, we have event-based surveillance, which we have been supporting the Ministry of Health to implement since 2019. We have very low involvement. It's fully integrated within the Ministry of Health programs, and communities report, or community health promoters report, predefined signals by the Ministry of Health. It has very wide geographic coverage, and it promises bringing out the signals and events that are happening at the community, casting a very wide net and reporting these events to the counties and also to the national level. We have the integrated facility-based surveillance, where we use fever among hospitalized patients and in outpatient departments in 10 public health facilities, and test for various pathogens of interest. And we collaborate both with the counties and also the national government. Recently, we adopted a modular system, which I will be describing in a subsequent slide. Now, the population-based infectious disease surveillance is one of the longest that we have run with the Ministry of Health and other partners. It's high involvement, a lot of resources that go into that, and really looks deep into the households and the people that we do surveillance on, but has limited geographic coverage in only 2 sites. Now, these multiple health facilities and communities, they serve as sentinel and early warning for pathogen detection. So I'll go ahead and describe the population-based infectious disease surveillance, which is a critical platform for public health research and surveillance. So like I said, we've implemented this platform since 2006. We have 2 sites, one in Nairobi and another one in Western Kenya. We have 2 different approaches. One of them is household-based, where these households are visited 2 to 3 times a year, depending on the need and resources which are available. And we have in each of those 2 sites, we have our health facilities where participants get free health care, but we also do conduct surveillance for acute respiratory illnesses, diarrheal diseases, and fibral illnesses, and test for a variety of pathogens of interest from time to time. Some of the key achievements from this main platform has been determining burden of key syndromes and pathogens, including pneumonia, influenza, typhoid, and so on and so forth. We've also provided evidence for introduction and evaluation of new vaccines, including PCV10, rotavirus, COVID-19, typhoid, and RSV in Kenya. And of course, there are multiple publications which have been written. Some of the new directions on this is that we are starting a One Health site out in Eastern Province, where we want to look at the interface, not just of the infectious diseases, but also in communities that raise different types of animals. We are also exploring the interface of infectious disease and non-communicable diseases, and also looking at how environmental surveillance interfaces with the infections that are experienced in the human populations. So I brought this slide here. It's an output from the PBITS platform, and I wanted to show 2 things. We stood up COVID-19 surveillance in May of 2020. We had a break when most of the response, or most of these activities at the health facility were stopped. But in May, we started testing for COVID-19. So if you look at the top graph, it's from Kibera in Nairobi, and the red line shows you the positivity over time. The gray bars, they represent the number of samples which are tested per week. usually between 50 and 100. And then if you look at the purple bars, which I know you cannot see from back there, by November of 2020, we demonstrated a seroprevalence of about 43%. By March of 2021, it was at 56%. And by June of 2021, it was 64%. This information at that time was very helpful to show how much spread had happened in the communities in Kenya. Now, if you look at the lower graph, it shows, I lifted this from the Kenya MOH CTRAP of February 2022, and I wanted to show you how the data from the population-based site in Nairobi compares to the national COVID-19 waves, and it demonstrates how Kibera as a site is a sentinel for SARS-CoV-2 in Kenya. Generally, persons who live in Kibera work in every single sector in Nairobi, and when we continually conduct surveillance in this population, we are able to tell when COVID-19, for example, or any other pathogens that we have surveillance on is circulating in the Raja population. So this is a slide which I wanted to demonstrate two things on the integrated facility-based surveillance platform. One is that we are in diverse sites across Kenya in different health facilities, but most importantly, we did take a modular approach in this sense. We realized when COVID-19 hit that we were conducting AFI surveillance since 2017, but we needed to amend our protocols for us to do SARS surveillance or to test for SARS-CoV-2. So we wrote a broad protocol that encompasses AFI surveillance, SARS surveillance, AMR surveillance, surveillance among healthcare workers, and also mortality surveillance. But most importantly, we have an opportunity to stand up surveillance for any other pathogen of interest when either the national UC or the county UCs have been activated and allow us to test for pathogens of interest. So this is a slide from our AFI surveillance that we've conducted since 2017. And I brought it here to show two things. One, we use a multi-pathogen tool through a molecular multi-pathogen tool with 33 pathogens. And when we test specimens from people who are hospitalized with acute febrile illness, one of the things you will notice is the big piece of the pie, which is gray, which is 57%, which represents that for these patients, we did not detect any pathogens of the 33. And then the next thing you'll notice, of course, is the red piece of the pie, which represents the plasmodium. Obviously, this is a molecular method. We recognize that some of these are not, it's basically background parasitemia. But how have we used this information? We've used this information working closely with our PMI colleagues to ensure that all these places where plasmodium is being detected, of course, malaria is very common in Kenya, that they are all linked to treatment. But number two, we are using this information to change our testing algorithm to improve detection and also explore what are these etiologies that could be causing the rest of the people to get hospitalized in school. So what you might not be able to see with the smattering of the others include plasmodium co-infections, but also some key pathogens which are not normally tested for, including rickettsia and Bartonella, among others. So we do, on the response beam, we have stood up in collaboration with the Ministry of Health and other partners, national and 19 county EOCs, which collectively represent about 50% of the Kenyan population. They're in the blue-colored counties. And the setting up focuses on three main things: peoples, processes, and also technology and tools that can be utilized in these EOCs. But for me, coming from surveillance, one of the most exciting opportunity that I see and that we have optimized is linking event-based surveillance, risk assessment, and response functions to the county EOC. What this means is that when events are identified in the county, there's an opportunity for them to be responded to, which continually builds the culture of responding to small events, and effectively we are able to respond to events, big events when they do occur, without necessarily referring to the national level. The EOCs together collectively have responded to 100 public health events since 2020. I brought back the slide on FELTPs, not to talk about the numbers, but to highlight two things. One, the program or the curriculum is quite responsive to need, And one of our recent conversations that we've had with the faculty at the Ministry of Health is including health informatics as a core competency, just coming out of COVID, and based on the conversations we had yesterday, that we have to move with where we are going. We are going in the digital way. And some of the difficulties that we had in identifying technologies that could have helped us respond better to the COVID-19. And finally, the convergence of the detection from surveillance, from the laboratory, the coordination role of the EOCs and the trained workforce do contribute to strengthening public health capacity at the county level. What this means is that we are training FETP graduates, and then what happens is that when they go back to their counties, they have an opportunity to utilize the core competencies of how an EOC runs, the IMS structure, respond to events, and utilize their skills, and eventually they can only become better. So in conclusions, partnerships and collaborations are key. The Ministry of Health leadership and coordination of multiple sectors has allowed us to use resources and expertise effectively to maximize and sustain gains in health security. Collective preparedness is essential. There is no one pillar that is not important when you're responding to an outbreak. And investing in diverse health workforce is investing in health security. That's why we are all here. And finally, early detection saves lives, but we do have to continually address barriers to timely information sharing that shape effective public health responses. We work through and with many partners who I have represented on this slide. Thank you very much.
Thank you very much, Dr. Munyua. May I ask for questions? In the interest of time, there are 3 microphones in the 3 aisles. You may line up behind the microphones. I'd like FETP residents and graduates to ask questions as well. Please keep your question concise and complete. Tell us your name and where you work. Don't tell us your job description completely, please, all right? So please, I have a gentleman or a lady in purple. Please go ahead. And please tell us who you're directing your question to.
Thank you, dear presenters. I'm here to make an announcement. To those who registered for afternoon field visits, there is a lunch that has been organized for you, early lunch. So if you're one of those, kindly pass by reception downstairs, and a coupon will be provided to you based on the registration list. Thank you. Set off is at 1 p.m. in the parking lot. Sorry for hijacking.
Yeah. Thank you. Patrick, I think I see you. Go ahead.
Thank you. My name is Patrick. My question is to Penina. So during the opening ceremony, the chief guest of honor talked about the new acts that have been, the new bills that have been enacted to enhance UHC. So I just wanted to hear your comments about, you know, UHC, PHC, and global health and health security are interconnected. So in terms of CDC investment, what's your outlook in terms of achieving the IHR core competencies in the context of this new legislative framework, but also given the heavy community health promoters investment at the community level? So how are you looking at aligning surveillance, for example, community-based surveillance and other things with these new opportunities? And thanks for your presentation.
Thank you, Patrick. May I ask the gentleman with the striped T-shirt?
Bonjour.
Good morning, everybody. I'm from Benin. Intermediary FTP. My first question is toward Professor Adebola. The data on ACP for the prevention of infections are not available in our member states. So I would like to know if Agenda 2030 of ECP has a strategic and operational element when it comes to the data from different countries. I have another question to all the panelists. We know that communication is a very important point for public health. So we come up with a strategy. Among those strategies, so do we have a place for infodemies in this strategy? Thank you.
May we stick to one question per person? C'est seulement une question par personne.
Thank you very much. My name is Boku. I'm a Felty president from Kenya. My question goes to Dr. Penina Munywa. In your presentation, you talked of partnership in strengthening global health security, and you talked of over 40 years partnership and collaboration with Ministry of Health. So my question is, are there any plans of engaging other partners in the spirit of One Health approach? Because we all know that the next pandemic could be zoonotic in nature. So are there any plans to engage other partners in One Health, in the spirit of One Health approach?
Okay, and then the last question for this round from the lady in white.
Thank you. My name is Wangechi Gatai, Director of the Division of Global Health Protection, Tanzania. My question is, how do we elevate the conversation on global health security from the echo chamber that we have, talking to technical people, and yet what we need is really to elevate the conversation to the higher levels of government up to the presidential level. And I'm asking this in relation to what I've seen called the Universal Health Preparedness Review. Where does that fit in our conversation so that we move the conversation up to the next level of government? Thank you.
Thank you. I now call upon the panel to answer those questions. And once again, in the interest of time, if we can be as succinct as possible.
Okay, maybe I'll start. Thank you, Dr. Nguku, for your question, which is very loaded. Okay, thank you, Dr. Nguku, for your question, which is very loaded. Almost thinks I need to come back and give another presentation on what we are doing with universal health coverage. But maybe to say very briefly, CDC has been engaging with the Ministry of Health and other partners in the development of the the digital health bill, which was passed very recently, largely from the ongoing work through PEPFAR, HIV, AIDS, and TB. And we are working also with the government. We respond to the need of the government, and right now the focus is on universal health coverage. And like I said, some of our surveillance programs are at community level, and we are identifying ways that we can support surveillance to be an integral part of universal health coverage, recognizing that the community health promoters, like you would know, are the community. They're the ones who interact with populations. How do we leverage on those facilities to ensure that events and signals can be reported centrally and they can be used for response and for health security? To Dr. Boku, so when I say our partnership has been with the Ministry of Health, during the Global Health Security Agenda, we had worked with the Ministry of Agriculture and with other partners. But generally, CDC works through the Ministry of Health as our strategic partner, but we recognize that there is need for coordination as our main partner with other government departments so that all sectors are involved in the work that we do. So when I say we have had partnership with the Ministry of Health, does not mean we do not work with other sectors, but for health security, we work through the Ministries of Health, and I know you know that we have been implementing and have supported the development of a surveillance system for reporting of animal syndromes. So, thank you. I assume Dr. Wangeshi's question will be answered by someone else.
Merci pour votre question, mais je parlerai.
Thanks very much for your question. I'm going to speak in English to be clearer.
I think I'll be able to explain better in English. So the resolution was at the World Health Assembly this year. And you know that at the World Health Assembly, countries are represented, our ministers of health are there. So in a way, our ministers are aware. But sometimes, I guess, after the meetings, they may not remember all the things that they kind of agreed to. And that's why they don't attend those meetings alone. They attend with some directors who are meant to carry on those. But if you remember, I said one of the things that countries are supposed to do is advocacy. Bringing these things to remembrance, like the Agenda 2030, we just have about 7 years to go, and there is so much more to do. So it's part of our responsibility for being here to ensure that we can fulfill that agenda. Thank you.
Last but not least, there was a question on how do we improve communications moving forward. In my presentation, I did mention that this was an area that was unemphasized during the COVID-19 pandemic. CDC and WHO is actually working on a draft guidance on how to improve communications across countries and between regions. This document is currently being worked on, and I think that should be shared coming up. But as I said, that was an important area that was unemphasized and definitely should be at the front line. There was also a question on how do we get leaders involved. I think one of the things the US government is doing in countries is actually health diplomacy within the global health security, which is established with the US State Department. This is to engage countries and ministries of health at that level to improve health diplomacy, to make sure that actions are taken, not just at local, but to make sure that governments are involved in the planning and also implementation of global health security. And more on the US State Department website on the objective and overall mission of that new bureau, which was just recently established by Professor John Kengasong. So you can read more about that and the objective of that improving global health security through health diplomacy. Thank you.
Thank you. Thank you very much to our panelists. So what I'd like to do now is there might have been 2 or 3 people at the microphones. I'm going to ask those people to just come forward and you can talk to our panelists. For the rest of the group, please may I urge you to go to lunch because we are slightly over time. So those 2 or 3 people, please feel free to come forward and we can engage here. So thank you very much, everybody, and we are now going to lunch. Transport will leave at 1 o'clock promptly. Thank you. And a warm round of applause for our panelists. You are also welcome to engage with the speakers during the lunch break, at the lunch. Thank you.
Nice to meet you. Likewise. For keeping us on time.
Boom, boom, bang, bang.
Yes.
There might be somebody here who has a question.
Okay, I just stay up here.
Please go ahead.